And the pointer's over here and forward. Okay. Sure. Okay. Hello. The topic I'm going to be talking about today is cardiac involvement in Lyme's disease, particularly in children. This is to say it's a new topic is an understatement. We're on the horizon talking about it, and I'm sure in 2 years from now it'll be a very different type of lecture. What I'm going to talk about are the cardiac manifestations of Lyme's disease. That would include first-degree AV block, second-degree AV block, complete AV block, left bundle branch, right bundle branch, and the various forms of heart muscle problems, cardiomyopathy, congestive heart failure, and so on. We'll talk more about these in each part, but these are the involvements, and I'll go into detail, but these are the involvements that occur in Lyme's disease and Lyme's carditis. Now, the big question that always comes up is, what is the incidence of cardiac manifestations in Lyme's disease? I've read articles that quote statistics all over the place, from 1% to 20%, but the consensus seems to be that about 10% of children with Lyme's disease have cardiac manifestations. That can be the mildest of manifestations, such as first-degree AV block, which we'll talk about, or the more severe forms, such as complete AV block. But 10% of children with Lyme's disease will have cardiac manifestations. This is a statistic I found very interesting. What is the male to female ratio of Lyme's disease? And the ratio that the literature quotes many times is about 3 to 1 males outnumbering females. I have to admit, from all the patients I've seen, this data does not seem correct, at least out in practice. I would think the female to male ratio might be 3 to 1, but just to make it as a point of interest, the literature talks about the male to female males to females is 3 to 1, which I think many people would disagree with. I wanted to talk about, if we're going to talk about Lyme's disease in first-degree AV block and second-degree AV block and so on, it's only fair to talk about what are these terms. And I'll just fly through this quickly, but just to mention it. This is a heart, and this is a conduction system. The sinus node is right here. It sends out a signal. It's in the high right atrium. It sends out a signal that goes to the AV node, which is right here, then goes down to the heart muscle. The sending out of the signal in the sinus node creates the P wave on an EKG. And if we're going to talk about problems with Lyme's disease where it's so much affected on the EKG, we have to talk about these basic terms. The P wave is for the sinus node, sets off, fires a signal, and the atrium contracts before it comes down here. Again, the AV node, we said it fired in the sinus node, goes down to the AV node. This is probably the most important part of the conduction system right here as it goes down and fires into the ventricles. This is where heart block and delays in conduction can take place. If the P wave is here, the AV node represents the pause before the QRS. Once it goes from the sinus node to the AV node, it then goes down both left and right bundle branches as it heads out to the heart muscle. We then go out from the bundle branch blocks out to the heart muscles into the so-called Purkinje fibers. It's this contraction of the ventricle that gives the QRS complex. Now again, as we talked about before, it's the AV node right here. The sinus node fires, comes to the AV node and into the heart muscle. It's this area in the AV node where heart block and a lot of the problems with Lyme's disease can occur. This is the most sensitive area that seems to be affected in Lyme's disease. When you look at an EKG, and if you're going to talk about Lyme's disease and cardiac involvement, you have to look at EKGs. It's a number one area to look at. It's a very easy test to do. Any hospital has it. They're not especially hard to read, especially if you're looking for specific things. When you look at Lyme's, you're looking specifically, we'll talk about other things, but we're talking specifically and mostly about the PR interval, which is the beginning of the P wave, where the atrium contracts, where the AV node delays right here to the QRS. And the PR interval, which is the beginning of the P to the QRS, is a PR interval. This is what gets prolonged in Lyme's disease because this part gets prolonged as the AV node is delayed. Again, first-degree AV block, that term you always hear when you talk about cardiac involvement with Lyme's disease, is a prolongation of the PR interval. It should not, in adults, be longer than 0.2 seconds. In kids, it can be even shorter, but nobody would argue that a PR interval here is prolonged. I can tell you that when we run EKGs on kids with Lyme's disease, this is the most common manifestation. You need not treat it. They're usually asymptomatic from it. It's just an EKG finding. They usually have no symptoms related to it. But first-degree AV block is the number one problem that you see. Second-degree AV block is a different term, and this is a little more dangerous and something to look for. This can get you into trouble. Instead of having a prolongation of the PR interval, where I'm pointing right here, this is the P, this is the QRS, instead of having just a delay, you actually have a PQRS and then a P, and then the AV node is so affected that there's no conduction at all. This beats here, this is a QRS, this beats here, and then it stops. There's no beat conducted, which means if there's no beat conducted, there's no blood pressure being generated. Obviously, a long delay would be very dangerous. But when, this is important, in second-degree AV block, when the P wave conducts, it does conduct. It is associated. It may drop here, but this P and this QRS are definitely associated. This is third-degree AV block, the most dangerous form. These P waves are all beating at a regular pace right here. But by beating, they're getting stopped at that AV node, as I showed you before. There is no conduction to the ventricles whatsoever. These are escape beats that have nothing to do with normal conduction. You can see how slow the heart rate is. If these beats didn't generate, you'd have nothing. You'd have no blood pressure, no contraction. You can see how dangerous complete AV block is. The atrium is contracting, but it's getting stuck at the AV node, and nothing's getting through to the ventricle. Obviously extremely dangerous. These are the ones who get pacemakers for obvious reasons, and we'll talk about that. Something I'll mention in passing that we're seeing more and more on the EKGs, which I don't know how well is reported in the literature because it's harder and harder to find. Remember I talked about this being the AV node. This is the most dangerous area where complete heart block can occur, as I showed you in the previous slides. These are the bundle branches. Now, if one of these is knocked out, the other one can conduct, and eventually it gets to the heart muscle. So you can live perfectly fine with only one of these two, but it does cause EKG changes. And we have seen the so-called RSR prime on an EKG, which is abnormal, but I've seen this on Lyme's patients, and as they get treated and get better, then it reverts to normal, where you don't have this double spike. This double spike implies that one of the bundle branches is out. That's something we've been seeing in Lyme's, and when you treat them, they get better, it comes back to normal. The so-called extra beats, or premature ventricular contractions, is something we're seeing more and more of. The conduction system is perfectly normal. The sinus node generates a beat to this AV node, this sensitive area here. It goes down the bundle branches and into the heart muscle. But look over here, there's an irritable area caused by the Lyme's or many other reasons, which affects the heart muscle, and it starts firing on its own. And when you look at the PQRS, then you get this wide configuration here, which is a premature ventricular contraction. One of these, or just a few of these, don't matter. Runs of these in a row would be ventricular tachycardia, which could obviously be devastated. Isolated, uniform premature ventricular contractions are not normal, but we don't necessarily treat them. This is something, again, that came out in the New England Journal of Medicine in 1991. The clinical course of Lyme's arthritis in 46 children. AV nodal block was in 4 of 46, which is 9%. Again, we're very close to that 10% number that we talked about before. The 10% of kids with Lyme's will have cardiac involvement. This particular article from the New England Journal within the last 2 years talks about AV nodal block, whether it's first-degree AV block, second-degree AV block, or third-degree AV block, is about 9%, very close to that 10% number. So cardiac involvement does occur. This is a slide I took from an article, and it's amazing the types of how deep you have to go into the literature to find anything about Lyme's and heart disease, because it's just not well reported. This particular field is clearly in its infancy. I found this slide interesting because I just spent time telling you that first-degree AV block, the least dangerous, is the most common, and that's our experience. But if you go into the general population where you're not looking for problems, obviously if you have complete AV block, people are going to know about it whether you do an EKG or not. If you have complete AV block with nothing getting through, you're going to have a very slow heart rate, you're going to be fainting, you're going to be very obvious. But if you have first-degree AV block with just a prolongation of the PR interval, you're going to be totally asymptomatic. So it makes perfect sense that third-degree AV block would be easier to find in any particular subset of 100 patients, because 105 patients here, because you can see that third-degree AV block is seen in much higher numbers than first-degree AV block, whether it's the USA or Europe. Again, third-degree AV block, where they're passing out with very slow heart rates, is easy to find in a population. First-degree AV block can be very hard to find. If you don't do an EKG, how would you know it's occurring? I want to talk again about certain parts of the EKG, and then we talk about a P wave being here, a QRS. There's something called a repolarization, the so-called P wave, and it should be in the same direction as the QRS. And here you can see here's the QRS and the T wave is up. And when we look at EKGs, we're looking for nice, healthy, peaked T waves that look very nice compared to the QRS, a lot like this. This is an abnormal EKG. Remember I said you like it peaked? Well, here's a QRS, and here's an inverted T wave. This is something this is abnormal repolarization. This is something we're beginning to see a lot more in Lyme disease. We've seen them all over in adolescent patients. I don't know quite what to do with this isolated. I know it's abnormal. We can have kids on the floor with Lyme disease. You do an EKG on admission. Their T waves are inverted. You treat them with antibiotics, you do daily EKGs, every 2 or 3 days, you'll notice that it starts to get a little up and up and up, and then pretty soon by the time they go home, the T waves are then normal. I don't know exactly what's happening, but these kids are clearly improving their repolarization. They're beginning with EKGs like this, and if you follow them serially, they come up to normal. We don't treat it specifically, but obviously there's a change going on. On a different tact here for a moment, why is the pediatric cardiologist called to see a patient with Lyme disease? Obviously, the abnormal EKGs are a big part of it. But what about from a symptomatology point of view? The 5 things I'll talk about: chest pain, which Dr. Petruka alluded to a little bit in her lecture, palpitations, a feeling of a fast heart rate, an irregular heartbeat, I feel my heart skipping, a slow heart rate, which may or may not have symptoms associated with it, and the abnormal EKG, which I've certainly spent a lot of time with, and I won't talk much more about that. Let's start first. Why are we called to see the child with Lyme disease? Chest pain. The three reasons we see people with chest pain are, number 1, costochondritis. It's clear that they have chest wall pain. If you push on their chest, they complain of pain. If you give them anti-inflammatory agents, Motrin, Advil, any of these types of preparations, high-dose aspirin, they really don't improve as much as you might think they should. It is clear, though, that as they're treated and they respond from the antibiotics to Lyme disease, this costochondritis clearly does go away. Anybody who's seen these kids knows that they have costochondritis, sometimes excruciating pain. You treat them and this chest wall pain of costochondritis goes away. The second one is the most dangerous, myocarditis. Myocarditis is an inflammation of the heart muscle, assumedly from the spirochete being in the heart muscle. This is the most dangerous because it causes chest pain. It also causes life-threatening arrhythmias. And if you're not careful, if you're going to lose a Lyme's patient, it's going to be from myocarditis. This is why they all get echocardiograms. This is why they get EKGs. You look at the EKGs for those T-wave changes like we talked about before. You look at the echocardiogram for contractility. And that's why the echocardiogram is done. Do they have fluid around their heart? Is their contractility depressed from the heart muscle being inflamed? This is the most dangerous, myocarditis. We'll look for many kids just to rule out this one entity because these are the kids that get into major problems. The third one I have here is unexplained, which is clearly the most common. There are definitely children that come in, and adolescents in particular, that complain of chest pain. They don't have costochondritis because when you push on their chest, it doesn't hurt. They don't have a myocarditis because they have perfectly normal EKGs, and their echocardiograms show good to excellent contractility. What do they have? I have to be honest with you, I'm really not sure. Is it the nerves around the heart that are causing pain? Nobody knows this for sure. We do know that just like in the costochondritis, as they receive their antibiotics and as their overall Lyme's improves, their chest pain clearly improves also. This one I don't know what to do with. I believe it exists. Some people would say, well, the patients are just complaining, and I suppose it's true in a small percentage. But there's so many of them who have this unexplained chest pain of which they complain about, and there's so many of them that as they get antibiotics, this chest pain that we can't explain clearly improves. I wouldn't dismiss it. It doesn't worry me the way myocarditis does with the abnormal EKGs and echocardiograms, but it clearly exists, this unexplained chest pain. Palpitations. My heart is beating very fast. Well, the number one reason we see is the so-called supraventricular tachycardia. And if you can see this, you can see that you have a normal PQRS, and then bang, right on one beat, and this is important, on one beat it takes off into this fast rhythm over here. If it gradually increases, that's a sinus tachycardia. That just means that they got nervous, they went out and exercised. That's normal. This is a sudden takeoff. We see this supraventricular tachycardia. We do tend to treat it with the standard medications of digoxin and beta blockers and things like that. But I will tell you that if you don't get the Lyme's under control, you will not control the supraventricular tachycardia effectively. And they seem a little more resistant, and it frustrates the parents and to the cardiologists who are not in endemic areas. With Lyme disease, they keep getting digoxin and they keep getting beta blockers, and they can't control this, and they wonder why. And if you get the Lyme's under control, you will control this also. The second reason for palpitations, which I've hidden down here, is this unexplained, which again is quite prevalent. And I don't know quite what to do with this. There are many children with Lyme disease who complain that they feel their heart beating fast. You put on Holter monitors, which collects the heart rate over 24 hours, and no matter what you do, you can't find anything. They even write in the diary, while the Holter was on, I'm having palpitations. Well, you look at the exact strip when they complained, and the strip is normal. I don't know if they're more sensitive to their heart with Lyme disease. I don't know if they're just making it up for attention, but there clearly is a large population of patients who complain of palpitations, and even though they say it while the Holter is on, and even though they write it in the diary for the Holter, and we can pull the strip exactly when they had their complaint, and it's normal. So clearly something's going on here, and I don't know if it's an extra sensitivity or what's going on, but clearly there are many children with palpitations who do not have supraventricular tachycardia. You have to be able to find out with this one you treat, this one you don't. They both seem to get better when the Lyme's gets better. The irregular heartbeat. I feel an extra beat. This is what we talked about before, and we showed a slide of premature ventricular contractions. Those are those extra beats that just fire from the ventricular wall. As you can see, number one, premature ventricular contractions, which is exactly the picture I showed earlier with the extra beat in the ventricle. Premature atrial contractions, some with aberration. Well, a premature ventricular contraction obviously comes from the bottom two chambers, the ventricles. A premature atrial contraction comes from the upper two chambers. If they're aberrant, what aberration means is sometimes these premature atrial contractions should be narrow, the premature ventricular contractions should be wide. Sometimes premature atrial contractions are wide also, and it makes it hard to tell a premature ventricular contraction from a premature atrial contraction. We have a child right now over at Jersey Shore who throws these all over the place, and recently showed us a Holter from 5 years ago that was perfectly normal. So it's clear that this occurs. It's clear that this too does respond to treatment with Lyme's, treatment with antibiotics. Isolated premature ventricular contractions, I will not add any cardiac medications for. As long as they're isolated, they don't need to be treated. If they have runs of premature ventricular contractions, that's called ventricular tachycardia, and obviously that's a lot more severe and dangerous. Incidentally, when I told you before we worry about Lyme's myocarditis, it's the arrhythmia of ventricular tachycardia that they go into that can be quite life-threatening. I put this slide up again. These are run simultaneous, which means all three of these are being run at the same time, which means it's like this. And you can see these extra wide beats. This is normal, this is normal, this is not normal. This is a premature ventricular contraction. This is normal, this is normal, and here's another premature ventricular contraction. We do not treat these that are isolated like this, but they will respond as the Lyme's is treated. This is an interesting topic, the slow heart rate. Now, when I review the literature, all they talk about is complete heart block, which we talked about before in some detail. The isolated P waves with no QRSs that get stopped at the AV node, and there would be no heart rate if not for the ventricular escape rhythm. They talk about that in the literature. They talk about putting pacemakers in, and then when they get better from the Lyme disease, you take the pacemaker out. I think it's reasonable because if you don't do it, they can die in the interim from complete heart block. So you end up putting permanent pacemakers in on a temporary basis. What I find even more interesting is it complete heart block, which is blockage of the P waves, or is it sinus bradycardia, which is normal conduction but just very slow? I put this diagram up just to show you the difference. This is PQRS, PQRS, and you can see every P wave has a QRS here. And when you look at the so-called ladder diagram, there is a relationship between the atrium, the AV node, and the ventricle. The lines connect, which means the beat originates up here and goes to the ventricle, beat originates up here and goes to the ventricle. It parallels perfectly what's happening here. P wave, QRS right here, and then it just connects. This is obviously sinus bradycardia, which means that sinus node that we talked about before is beating normally, just very slow. That's in opposition to this, which is complete heart block. If you look up here, there's a P wave here. It looks normal, right? But there's a P wave here which does nothing. There's a P wave here that does nothing. There's a P wave here that looks like it might be reasonable, and then there's one out here. And if you look closely, one of the P wave has nothing to do with the QRS. They just happen to be in proximity. If you look at this ladder diagram and remember how they were connected before, you can see there's a QRS here, there's a P wave here, but they're not connected. Here they look almost connected. That's why this looks normal, but this is an accident. If you do enough of them, they'll end up together. This is here, this is over here, this is here, this is over here. There's no association between the P waves and the QRSs. This is important because we all agree that when you have complete heart block and dizziness and fainting, they're going to have a pacemaker. They're at risk. But what do you do when they have sinus bradycardia, which just means they're conducting slowly? Show you the next slide. This is a patient that I took from a halter at Jersey Shore on one of our adolescents on the floor. The strip is read correctly. The heart rate is 30. This was done at 3:51 a.m. The patient's asleep, but it's still 30. That's even slow for being asleep. The P waves are here, QRS, P wave, QRS, P wave, QRS. They are clearly associated. This is sinus bradycardia. And you can see here that they are associated. What do you do with sinus bradycardia? Do you put a pacemaker in someone who has just a slow heart rate? It's a very difficult question to answer. We're following these. We have not been putting pacemakers in, but I'm not sure what the right answer is. Okay. How much time did you say? Sorry, how much time was that? How much time? 1 minute? Okay. I'm going to cut this short then. The pathology of Lyme disease and Lyme's carditis, let me just mention the last one here is presence of spirochetes in the myocardium. After watching Dr. Fried show the spirochetes in the GI tract, it makes me wonder if I should go in and do biopsies. Obviously, that would be incredibly invasive for a heart since you could create arrhythmias, and I don't think we can do that at this point, but people have done it. Just let me finish up here since I'm told I have 1 minute left, and skip over to a couple things. I'll skip this and skip skip this and go to the last two slides that I wanted to talk about. Okay, important point, and let me just finish up here. The major cardiac textbooks do not address Lyme disease. And what I mean by that is that the textbooks in cardiology, you go to the index, you look up ventricular tachycardia, they have a whole chapter on it. You look up rheumatic fever, they have a whole chapter on it. You look up Lyme disease, it's not even in the index. You can't find it. What I did to put this lecture together was my own experiences plus digging deep into the literature through the computer files and everything else to see what was out there. In the mainstream population, people are writing 1,200-page textbooks and they're not including one sentence about Lyme disease and cardiac involvement. That's going to need to change over time. And finally, when I put this slide up, I feel like I'm lost sometimes in the jungle because it's just, there's no one to ask. No one knows any more about it than we do, and it's just, and like I said, in 5 years from now, this will be a whole chapter devoted to it in any textbook, but for now, a lot of us are just feeling our way as we go. Thank you.
We're running about a half hour late, so we're going to hold any questions right now until after the break, and we're going to go ahead with the adult section. Dr. Masters?
Again, we apologize, but we're going to have to hold the questions till the end of the presentations. It's my pleasure at this time to introduce Dr. Patricia Coyle. She's a professor of neurology at the School of Medicine, State University of New York at Stony Brook. She trained at Johns Hopkins, did an internship at New York Hospital at Cornell, and then returned to Johns Hopkins. She's a neurologist, and she's going to talk about rapid nervous system invasion by B. burgdorferi.
Great. Thank you. It's a great delight to be here, and I want to thank you for inviting me. I haven't spoken to this group before, but I'm certainly enjoying this colorful city. In the next 20 minutes or so, I'm going to be discussing neurologic Lyme disease in adults. I'm an adult neurologist. I'm going to begin with some introductory statements on how I think about neurologic Lyme disease and the current state of knowledge with regard to described syndromes of involvement. I'm not going to touch directly on diagnosis and treatment, except to point out the problems we currently face, which really direct where our research should be going. I'm then going to turn to some experimental studies from my laboratory, looking at cerebrospinal fluid collected from patients with early B. burgdorferi infection. And I'll speak about two research assays. One, analysis of CSF using an antigen capture ELISA for OspA, which you've been hearing about. That's an antigen, a protein specific to B. burgdorferi, and I believe that offers direct evidence for neural invasion by the spirochete, and detection of complex anti-B. burgdorferi antibodies, which Steve Schutzer discussed with regard to blood this morning, and I believe that that indicates indirect evidence for neural invasion by the spirochete. Clearly, we recognize the nervous system is one of the targeted organs in this systemic infection. In people that become clinically ill after they're exposed to B. burgdorferi, the nervous system is involved in 10 to 40% of reported series. And clearly both peripheral nervous system and central nervous system syndromes are well described. Now we know that neurologic involvement early in the infection, even if it receives no antibiotic treatment, will tend to remit spontaneously. This tends not to be the case, however, in the late syndromes, and clearly argues for early detection of neurologic infection with eradication with appropriate treatment. One thing I like to remind myself is to keep an open mind. I think currently that we have not fully defined all of the possible neurologic manifestations of Lyme disease. Okay. I I like to approach syndromes of the nervous system in terms of characteristic ones of early and late infection, unusual syndromes in which there's pretty good data that Bieberdorf-Rye is the major factor, and then the problematic area of post-treatment or post-infectious syndromes. We all well know that there are characteristic early nervous system syndromes, the, quote, aseptic viral-like meningitis or meningoencephalitis, uni or bilateral Bell's palsy, that's clearly the predominant cranial nerve involved, and various forms of radiculoneuritis. In addition, there's increasing experimental data that headache is probably a manifestation of early CNS seeding by Bieberdorf-Rye. And then we've heard a bit about characteristic late-stage syndromes, including a mild encephalopathy characterized by difficulty with concentration, memory, attention, a mild polyradiculoneuropathy characterized by pins and needles sensation on extremities or shooting pain, and various forms of meningoencephalomyelitis where you have parenchymal involvement of brain and spinal cord to give syndromes that may mimic multiple sclerosis or brain tumor, for example. There are some more unusual syndromes in which there's increasing evidence that they're due to Bieberdorf-Rye. One is in children, a syndrome of increased intracranial pressure with papilledema that mimics the so-called pseudotumor cerebri syndrome. This doesn't appear to be true in adults, so it appears to be age-specific, which is an interesting phenomenon. Bieberdorf-Rye in some cases has been related to various forms of vascular disease. In unusual cases, it can present with syndromes that really mimic primary psychiatric disease, probably as a manifestation of an encephalomyelitis, and primary muscle involvement. These are much, much less common than the other characteristic syndromes that I described of early and late infection, but there's pretty good data in the literature that Bieberdorf-Rye can produce it. This is a problematic area. Patients have Lyme disease, they get treated, and yet they persist with problems such as headache, encephalopathy, a syndrome that really mimics chronic fatigue syndrome, and a syndrome that really mimics fibromyalgia syndrome. We don't know the etiology here. We don't know which of these patients are persistently infected, which have had a self-sustaining immune and inflammatory response triggered by the spirochete. This is an interesting area, really, that warrants a lot of future research. When we consider current problems in the diagnosis of neurologic Lyme disease, one is the fact that unlike most bacteria, for all pragmatic purposes, you can't culture or stain for Bieberdorf-Rye. So I can't spinal tap a patient and send off the CSF asking them to culture it for the Lyme agent. Unfortunately, we have no readily available assay for active infection in this disease, and that creates a real diagnostic problem for us. EM, which is the one characteristic marker, is seen in only a subset of patients. In the literature, perhaps 70%, perhaps even lower than that. If you rely on serology, which can document exposure to the agent, you will miss seronegative cases, which make up at least 7% in well-characterized series, and you'll also overdiagnose false positive serologies or asymptomatics, people that have been exposed but have contained the infection and still have antibodies as a memory phenomenon. And as we've heard, serologies, there are really problems with this assay. And in the best of hands, there's a built-in false positive rate. So we have a lot of diagnostic problems in neurologic Lyme disease that we need to address. We also have a lot of problems in the therapy of neurologic Lyme disease. One big one is that when you attempt to study in the test tube the response of an antibiotic drug to Bieberdorf-Rye, it will very often conflict the results you get with what actually happens in vivo, and that's a real problem. There have actually been surprisingly few controlled human studies of antibiotics to treat Lyme disease, and in particular neurologic Lyme disease. We don't have a reliable antimicrobial cure criteria. By this I mean you can't say, I treated the patient with antibiotic X and I documented that they became culture negative. Unfortunately, we can't use that in Lyme disease. As a matter of fact, we have to say that the optimal antibiotics, dose duration, and drug route are really not known yet for neurologic Lyme disease. And we also must admit, to our chagrin, that all current regimens have had treatment failures and treatment relapses, and we need to address that. The post-treatment, post-infectious syndromes create problems because how do we know why patients have persisting symptoms? Is it because they're persistently infected, or is it because a self-sustaining inflammatory immune response has been created by the prior infection? So a lot of problems remain that we need to solve with regard to treatment of neurologic Lyme disease. I think it's useful, as other speakers have done, to think about Lyme disease in the context of what we know from a lot of prior work on spirochetal infections in general. B. burgdorferi is a spirochete, and there are a number of other spirochetes that also cause neurologic infection and which have been studied for some years. And these include syphilis, leptospirosis, and relapsing fever. And there are certain features that we know that these spirochetal nervous system infections share. And one would think that that would help us predict what Lyme disease would do. We know that spirochetes disseminate widely after their initial infection, that they frequently seed the central nervous system, that the central nervous system can serve as a protected reservoir for persistent infection, where a limited number of spirochetes can persist, only to reactivate and cause later disease process. This is something that I've been interested in from the point of view of B. burgdorferi. We know, for example, in syphilis that treponema pallidum seeds the central nervous system in 40% of primary and secondary infections. In my laboratory, we've been interested in looking at cerebrospinal fluid and examining it in patients infected with B. burgdorferi. And I'm going to show you some recent work on early infected patients. These were all patients who underwent spinal fluid examination for suspected neurologic Lyme disease over a 9-month period at Stony Brook. They had all been ill for less than 3 months, so they were short-term early infection. And these were unselected patients, all comers. There were 25 people, half women, half men, aged 15 to 80 with a mean of 43 years, and they had been ill for as short as 1 day to as long as 3 months. But the median duration of illness was 2.5 weeks. So this was a pretty early group. 10 of the 25 had actually completed a course of antibiotics before they underwent lumbar puncture. In almost all cases, it was oral. There was one case, I believe, of intravenous. We collected blood and spinal fluid on these patients, and blood was analyzed for anti-B. burgdorferi antibodies by ELISA, as carried out in the clinical lab at Stony Brook, and for complexed antibody, as Steve Schutzer reported this morning, and we looked for complexed IgM and IgG on blood. With regard to the CSF, we did routine studies. We did anti-B. burgdorferi antibody. We also looked for Borrelia-specific immune complexes, complexed IgG and IgM, just as in blood. And we did an antigen capture ELISA utilizing monoclonal and polyclonal, specifically directed against OSPA on spinal fluid. The bulk of our patients had EM, 68%, almost 70%. In only 16% was it disseminated. So this is really the earliest clinical stage of B. burgdorferi infection. That was the bulk of this group. 16% of patients had a Bell's palsy. There was one interesting woman that had EM 2 months earlier treated, and then 8 weeks later relapsed with her Bell's palsy. We tapped her at that point, so I included her in this group rather than the first group. 2 patients with tick bite followed by a constitutional syndrome, including headache, stiff neck, muscle pains and aches, and 1 patient with meningitis and 1 patient with a picture that mimicked Guillain-Barré syndrome. When we looked at results of blood, about 3/4 of the patients had a positive or a borderline ELISA for anti-beta-dorfli antibody. When we looked for complex antibody, there was a higher proportion, 82% were positive, mainly for IgM, not unexpected in an early infection group. It doesn't seem to be advancing. There we go. Okay. When we looked at CSF and we looked at conventional, only 20% of this group had a mild pleocytosis. This was the meningitis patient. Only 1/4 had an increased CSF protein. There was a positive or borderline antibody titer in about half of patients, but only 17% had intrathecal antibody production. And many people would consider this not an abnormal finding. If the antibody titer is less than a concomitant serum, it could be explainable by simple leak of blood, and so they would not even consider that an abnormal CSF finding. So there wasn't a lot of abnormalities in the conventional studies. When we looked for antigen by our ELISA, 36%, 9 of the 25 were positive. When we looked for complex antibody, 72% of the group were positive. You remember that a free antibody, either positive or borderline, and I'm not even reporting the borderline here, was seen in only 50%. Again, predominantly IgM. That's not surprising. Okay. So if we look at the routine studies and we accept positive or borderline free antibody titer as an abnormality, 60% of this group of early infection patients was abnormal. If we discard a free antibody titer that was lower than the concomitant blood titer, which many people might do, conventional spinal fluid tests were abnormal in only 36% of this group. Yet 80% had either CSF antigen or complex specific antibody detectable. And if we combine routine and research studies and asked how many of this group of patients with early beta-dorfli infection had an abnormality, it's 88%. Now let me just briefly run through the subsets of patients. I've just given you the lump data for the whole group. This is the patients with EM, which were the predominant, and they're divided up here into patients that had had no prior treatment, which were 9, and their mean duration of illness was only 7 days. And then 8 patients that were actually tapped after they had received the course of antibiotic treatment, so that they had a longer duration of illness. Actually, the mean was 6.5 weeks. If we look at this very early group, most of them had complex anti-beta-dorfli antibody detectable in spinal fluid, and 1/3 had antigen. This is now erythema migrans. 1/3 were antigen positive in CSF. Other abnormalities were uncommon. If we look at the later EM with spinal fluid collected after treatment, again, 5 of 8 had complex antibodies, and 1/4 were antigen positive. 25% were antigen positive in their spinal fluid. If we look at the Bell's palsy group and the CSF abnormalities, finding complex or free antibody was most common. But what I would point out was that half of these Bell's palsy patients were antigen positive in the spinal fluid without other striking abnormalities. If we go to the 2 patients who had a tick bite followed by a constitutional syndrome, very early in one case, post-treatment tap for a persistent headache in the other case, both had Borrelia-specific immune complexes in their CSF in the absence of free antibody. The patient with meningitis was certainly CSF antigen positive, complex antibody positive, had intrathecal antibody production as well. The patient with a syndrome mimicking Guillain-Barré was also antigen positive, complex antibody positive in spinal fluid, was free antibody positive without intrathecal production, had an elevated protein. If we look at the patients in this early B. burgdorferi infection group who were antigen positive in their spinal fluid, 3 patients with disseminated EM, 2 patients with treated EM who were spinal tap because they had persistent headache, 2 patients with Bell's palsy, and the one with meningitis and the one with the acute polyradicular neuropathy. To sum up, and I address the upper part of the slide here, I would say that in this group of early infection patients in whom we examined cerebrospinal fluid, we found that CSF, if experimental assays were used, was abnormal in a high proportion of early infection patients, particularly with headache, and most of the patients that underwent lumbar puncture underwent it because they were complaining of some form of headache. OspA antigen and Borrelia-specific immune complexes in some cases were found in the spinal fluid in these early infection patients without any other abnormality of conventional routine assays such as pleocytosis, intrathecal Lyme antibody production, or increased protein. And we would interpret these findings as supporting that, as is true of the other spirochetal infections that can produce neurologic disease, B. burgdorferi also in a significant proportion of patients seeds the central nervous system at an early stage, even at the erythema migrans stage. Thank you.
Thanks for an excellent talk. Our next speaker is Dr. Lesser, who is a neuro-ophthalmologist associated with both Yale and the University of Connecticut, and my pleasure. Again, we're going to hold all questions till the end of this afternoon, so we can catch up a little bit.
Thank you very much. First of all, I again would like to compliment the Lyme Foundation, and particularly Karen and Tom Forstner, for continuing these meetings and seeing another huge success. And I'm just delighted to see so many people here and congratulate you on the excellent work you continue to do. It's hard to start something, it's hard to continue. So congratulations. In terms of the eye findings, I will let you relax a little bit. I think that was just a superb talk, and I'm sandwiched here between neurology and skin, both of which are sort of primary targets for Lyme disease. And I think probably one of the most important things before I show you my list of, my litany of eye findings that can be involved, is that this is not that common. And I think that it makes it more difficult as a result, because when we try to determine if the association with the eye findings is coincidental in a patient who happens to have Lyme disease or is related to it. And I think that we've collected a series of patients over the years where I think that we have some support that eye findings do exist, and I think it's important to be aware of it, particularly in endemic areas. Now, can I have the first slide, please? Good. Now, eye findings were actually first reported in Alan Steele's original paper, published in 77, first observed in 75. And what was found in those cases was that there were a group of patients who had a follicular conjunctivitis. And in that series, about 10 or 11% of the patients had complained of a conjunctivitis. And with that, and then that figure has stayed in the literature, although that's been actually very difficult to study further. That particular study was done in retrospect and wasn't done with ophthalmology. So that figure, my own sense of it is that figure is a little bit on the high side, but a follicular conjunctivitis definitely does occur. Associated with it, there are also reports of subconjunctival hemorrhages, photophobia occurring in patients and some vague symptoms like floaters. The problem with this is that these are so nonspecific, although I sense that they do occur with patients, they're very hard to look upon this as sort of diagnostic of Lyme disease. Probably the most interesting of the eye findings that we've seen really are the corneal findings that we've seen, and there are really two main groups. The first is the nummular keratitis, little spots distributed throughout the entire cornea, and then another which is interstitial keratitis, I'll demonstrate both of those to you. The nummular keratitis is seen in this diagram here from a paper we published in '89, and you can just see that you have these multiple irregular opacities that can be distributed throughout the entire cornea, and usually don't have any surrounding edema, have very irregular borders, and can interfere with vision if they happen to be in the visual axis. We've seen it in patients where they've been asymptomatic, and in other cases where their vision has been decreased from this. In most cases, you'll see this for months to years after the onset of the Lyme disease, even in patients who have been treated. So my sense of it is that in many cases this is an immunologic phenomenon rather than direct infection, although we don't have clear-cut data to support that. This is actually the first patient we saw with this, and you can just see I have these little peripheral opacities here. And here's a close-up, and you can see a very nice view of these sort of whitish kind of opacities here, really not causing much discomfort to the patient, particularly if they don't have a red eye at the time, they may not be aware of them. And this is another close-up. Here you can see this is actually a patient from the shoreline of Connecticut. You can see these opacities right here also. This particular patient had a coincidental 6 nerve palsy, which we'll talk more about. Now, the other major corneal finding is this interstitial keratitis, which is a diffuse type of inflammation throughout the stroma, through the deep part of the cornea. It's much more profound than the nummular keratitis and really causes a significant associated decrease in vision. Interestingly enough, interstitial keratitis is also seen in syphilis, particularly congenital syphilis, and is also seen in leptospirosis. So that this wasn't that surprising. I didn't really go over this history. Let me go backward if I can. This particular case that we saw was a young girl who had the classic constitutional symptoms of Lyme disease with the ECM rash, and she, as you can see, had a markedly elevated titer. And 6 months after the development of her Lyme disease, developed the nummular keratitis, these deposits within the cornea, and then about 10 months later, even after treatment, went on to develop interstitial keratitis. She was eventually treated with IV Rocephin and had significant but not complete improvement. And here you can see this kind of diffuse opacity, the opacification of the cornea right here, which eventually did clear but left her with a significant amount of corneal scarring, as you can see. This is just a reflex from the slit lamp beam that you're seeing. Now, as I mentioned before, our sense of it is that this probably is on an immunologic basis, basically because we've seen this in patients who've been treated. We find that, particularly for the nummular keratitis, that if we use topical steroids, that these will clear. We don't usually recommend that they be retreated unless there's some other evidence, constitutional evidence of Lyme disease. The previous speaker beautifully outlined all of the complex issues in terms of the neurologic problems, is that you can't be sure about the diagnosis or the treatment, and sort of the same issue applies to here, something which occurs with much lower frequency. Now, the differential diagnosis to the ophthalmologist for these little spots in the cornea would include infectious mononucleosis, mumps, and a couple of other rare causes. One of the other findings that we see within the eye is sort of a diffuse inflammatory syndrome within the eye, uveitis. And uveitis, in many cases, is something that the ophthalmologist will see and really will not be able to make a specific diagnosis. The differential diagnosis is broad, and I think, again, in these type of cases, you have to meet certain criteria so that expected this to occur in an endemic area. There would be found disease in other organ systems, as I'll outline further. But I think there's no question that there have been cases of uveitis associated with Lyme disease. And just to illustrate, this is a manifestation of some of the anterior changes, and you can see these what are called posterior synechiae, or adhesions, resulting from the inflammation. So you see these adhesions between the iris and the lens. And this is another patient. I just lost that slide. I was going to show you another patient that we just saw who had a similar finding. Can someone just please advance or save the slides, please? Terrific. Okay. You can just advance beyond that. Associated with the uveitis, you basically can get inflammation anywhere within the eye as a result. So they're not. Can you just bypass the next slide and go on to the ones after them? You can see inflammation within the retina, the choroid. This is actually that slide of just the other patient illustrating again the synechiae that this patient. Interestingly, this patient who comes from Dutchess County did not have a positive titer, but had a history that's strongly suggestive of Lyme disease and did respond to treatment. This patient also had evidence at one point of a swollen disc. And I'll show you more examples later on. This kind of hazy, fuzzy picture of what you're seeing here at this point is just sort of a diffuse inflammation through the vitreous of the eye. And these are just sort of fluffy white material that you're seeing here. And again, this type of uveitis can be caused by Lyme disease. I think, again, the same sort of criteria. I would not be willing to attribute the uveitis to Lyme disease unless I had a lot of other supporting evidence. And this is just an example here of a patient who was with the associated uveitis, also had disc edema. And this is a patient, actually this is from Dr. Bialchowitz in Europe, and you can actually see this whitish material right here under the retina corresponds to infiltrates from the choroid that were from Lyme disease. And that's now illustrated on this fluorescein angiogram where there is dye that's injected intravenously and then will leak into the choroid, and this corresponds to the areas of active infection. This was a case report that he presented quite a few years ago. So this sort of summarizes, as you can see on the list, the ocular inflammatory syndromes. Some people feel that there may be, one of the types of inflammation is a pars planitis, or a type of inflammation in the most peripheral portion of the retina and at the junction of the end of the retina, called the pars plana. And associated with that, you see these sort of greasy, fatty deposits right on the cornea. And the combination of these two have been reported more frequently in Lyme disease than some other causes. So the vitreous clouding I mentioned before. Orbital myositis, which is basically an inflammatory disease of the extraocular muscles, was reported a few years ago from Colombia. And basically what the patient had was a rather large, thick muscle on imaging study. And the patient had associated inflammatory findings of redness, irritation, and diplopia, double vision. The most dramatic case was actually presented, was the last one, is so-called endophthalmitis. And this actually, Dr. Duray had something to do with this case also, since that he identified the spirochete. This was a patient living in Westchester County who had a flu-like illness with an ECM rash, whose titer, as you can see, wasn't that dramatic, and developed 6 weeks after this sort of the constitutional symptoms of Lyme disease, developed a significant inflammatory syndrome within the eye to the point that it was felt it was most likely an infection within the eye. It was endophthalmitis, and the patient was treated in ophthalmologic terms in the standard manner with systemic antibiotics, but was used, Keflex was used, and in addition there was intravitreal injection of gentamicin, which is the standard approach that ophthalmologists would use for most serious infections within the eye. In spite of that, the eye was lost, and it was eventually, the vitrectomy when it was done was negative, but when the vitreous specimen was reviewed by Dr. Steele and Dr. Duray, they were able to demonstrate a spirochete within the vitreous, and this slide is courtesy of Dr. DeRay. And it's a rather dramatic example of the degree and extent to which the eye can become involved. And just in the same way that the central nervous system can be invaded early, there's good animal evidence that the eye is also invaded early. And of course, in corresponding disease like syphilis, the eye is also frequently involved both early and late. Now, my particular area of interest is neuro-ophthalmology, and we've seen a number of patients who have had optic nerve involvement as well as having cranial neuropathy. And I'm delighted about the comments by the last speaker in reference to pseudotumor cerebri, and I would agree completely with that. Let me just illustrate here. This is a slide from a patient who presented with bilateral disc edema, had cells in the spinal fluid, and basically this patient had an aseptic meningitis associated with Lyme disease. I think, and for any of the pediatricians in the audience, it is inappropriate to use the term pseudotumor cerebri because that really means that there is no associated disease with this. Perhaps it's splitting hairs for the non-ophthalmologists, neurologists, and neuro-ophthalmologists, but it's very important to me because it sort of crept into the pediatric literature. And I think that these cases represent meningitis with elevated intracranial pressure with or without associated sixth nerve paresis. And that other patient that I showed you before who had the uveitis also had at one point bilateral disc edema with elevated intracranial pressure. And again, I would agree with the last speaker that this seems to, for reasons I'm not clear, occur more commonly in children than in adults. Now, we reported a few years ago 2 patients with optic neuritis, and again, it's always very difficult to be sure, is this optic neuritis really associated with the Lyme disease, or is it coincidental? Most of the times, optic neuritis turns out to be associated with multiple sclerosis, although it can take many years until the multiple sclerosis will manifest itself. And in some good studies, it's been shown that probably the patient has an episode of optic neuritis, a woman, that probably has about a 75% chance over a 15-year period of developing multiple sclerosis. Now, this is not as good an epidemiologic study as you might want, but it's based on sort of a tertiary referral center, but I think that there is other sort of anecdotal evidence that would support that. In men, I figure is probably close to about 35%. So as a result, it was difficult for me to present to my neuro-ophthalmic colleagues these cases of optic neuritis and convince them that it was associated with Lyme disease. But I think the cases that I felt comfortable attributing to it were those that had other constitutional symptoms, systemic symptoms you can see right here, and actually had a reasonably good response to treatment and also had positive titers. So that I think that there is optic nerve involvement, and certainly it's been reported in Europe, and I think although it doesn't occur that commonly, the optic nerve is involved, and it's so that you can get an optic neuritis, a perioptic neuritis, as a result of Lyme disease. Now, this is a case that actually was from California. It was caused by Ixodes pacificus, but you can see this is a so-called neuroretinitis, and that you're seeing these sort of exudates and deposits within the macula, which is the central part of the retina. And this patient also had enough criteria that we felt we could attribute it to the Lyme disease, and this has been reported at least one other time in Europe, and this is again from Dr. Bialchowitz, and I'm now aware of another case that actually occurred, and his patient had just been seen at Hopkins, and this is an actress who apparently recalled the tick bite after there was further discussion about this. So I think that neuroretinitis is probably there's more and more evidence that this is associated with Lyme disease, etc. Now, the cranial nerves, as alluded to before, that basically, first of all, what you can expect is that by far, of course, the seventh nerve is the most common, and a bilateral seventh nerve, as you can see by the evidence of the inability to close the eyelids completely here. In bilateral seventh nerve paresis in an endemic area, I think is Lyme disease till proven otherwise. I think in non-endemic areas, and depending upon the socioeconomic group you're dealing with, it still may be sarcoid is the most likely cause. But I think it's something we have to be strongly suspicious of. And in the original paper by Packner and Steele, I think it was about one-third of them had bilateral sevenths. Now, the fixed nerves, this is a gentleman who actually had classic Lyme disease with the rash, and then a few weeks later developed the right sixth nerve paralysis. He did not have elevated intracranial pressure, and we've had a few patients that have presented with sixth nerve palsies as signs of Lyme disease. Nowhere near as common as 7, but again, it does occur. And I'll present an interesting case afterwards to you. This article by Nelson last year in Neurology had come out, and what was interesting about this on MR demonstrated that although this patient only had 7th nerve involvement clinically, there was involvement of 5 and 3 that you could see on MRI scans, so there was enhancement. Now, I have attempted to look at this in some patients afterwards, and I have not been able to reproduce this. I'll be curious if any of the other neurology people in the audience have any comments about this later on. But I think it's an interesting observation. A couple of minor things. There have been some pupils that have been reported. One is a Horner syndrome, which I believe, and actually comes from Philadelphia. Dr. Galetta, who's at the University of Pennsylvania, was kind enough to loan me these slides. This was a patient who had, you can see the drooping lid on this side, and this pupil is actually smaller. This patient, after treatment with Lyme disease, the lid went up and the pupillary inequality reversed itself. I would have been skeptical if I hadn't really seen the slides in detail, but I'm willing to accept it. There has been at least one case reported of an Argyll-Robertson pupil, but there were no details of that, and so I don't really accept that yet. Finally, I would like to at least leave you with this one case of a 59-year-old man who presented with a left sixth nerve palsy, and about 3 months later, this isolated sixth nerve was then started to be accompanied by some numbness on his face, tongue, and fingers. He had at that point, he was from North Carolina, had a significant evaluation, was negative, but in 1985, he went on to develop bilateral sixth and bilateral seventh nerve paralysis, but this was really in the early days of Lyme disease, and it wasn't until his daughter was diagnosed as having Lyme disease that he then suggested that he had the studies done that was turned out to be Lyme disease also. He went actually on to develop decreased vision in his left eye because of the significant Bell's palsy and because of a cataract on that side. He had exposure problems to the cornea on the left side. In the right eye, though, his vision was 20/20, but within a 2-week period, his vision dropped from 2020 down to 2030, and he had signs that would suggest optic nerve disease, and within 2 weeks, he went from 20/30 in the right eye to 20/200 and had significant visual field loss. And we worked to know if this is his optic nerve. This is actually just a normal myelinated fiber here, which means nothing. There's a little bit of disc power that you can see at this time. But this is his field. This is the remaining visual field that you can see here and here. And basically what we think speculated and reported on him was that we felt that the Lyme disease, by whatever mechanism, whether it was direct invasion or on a vascular basis, caused a significant damage to the nerve and eventual significant optic atrophy developed. This is his MRI scan, and you can see these sort of periventricular enhancement right in these areas, these bright objects right here, which can be seen, of course, in Lyme disease. Now, as I alluded to before, that in order to make or accept a diagnosis of a relatively uncommon finding in a disease like Lyme disease, that you have to at least have some criteria, and I've listed them up here, and I think living in an endemic area, having positive serology, having disease in other organs, and having response to treatment are all things that would suggest and support this being associated with it. So in all likelihood, we're probably underreporting this because there are many cases that I've seen where I just really can't be sure, and I'm not willing to therefore call it. There are others, of course, come in who really have unassociated eye findings with people who may or may not have Lyme disease. And again, as we mentioned, the pathogenesis of these findings may be one of any three, from direct infection to immunologic to vasculitis. And finally, Additionally, this is just one of my favorite slides from a museum in London to illustrate that there can be eye findings in many systemic diseases, and I think it's important for ophthalmologists and for all of us to be aware of this. And finally, remember that this is the area that it all started, and thank you very much.
That, but you're welcome to go elsewhere if you want. Most of the discussion continues on from the daytime at night, and people from outside this conference will be coming in to ask their questions also. Thank you.
Again, 15 minutes. We're going to start back promptly at 3:30.